What is it like talking to a patient during the brain surgery?
Feel peace talking to them
Okay.
because it's like sitting in a clinic.
Mm-hmm.
Yeah, our tone will be more specific, the task oriented. So when we are closing and finishing, I'll keep on talking about it. So
Okay.
I'll be informing her, yes, the patient, the surgery is done very well. Now it's going to close soon. Are you okay? Yes, I'm okay.
Okay.
You feel pain? No pain. Any score? Zero pain.
Zero, okay.
Yeah, that's most important.
Mhm.
Yeah, the patient will not feel any pain during the surgery.
Hello everyone, welcome back to another episode of KoPiJom. Today we are at a very special location. We are at KPJ Sabah Specialist Hospital. With me here today I have Dr. Ananda Arumugam, consultant neurosurgeon at KPJ Sabah Specialist Hospital. Today we will be discussing all about inside the brain, stories, myth and surgery. Doctor, thank you for coming. Thank you for joining us today.
Thank you for inviting me for this podcast. All right. So I'm Dr. Ananda. All right. So I'm a consultant neurosurgeon in KPJ Sabah. If you would like to know about my background, I did my MBBS in Manipal. Then I did my master's in USM, University Science Malaysia. I've been a neurosurgeon here in Sabah since 2014. Then before that, about 5 to 6 years, I got a master's training, intensive master's training. Yes.
Is there a particular reason why you chose neurosurgery instead of other specialization?
During my housemanship, and we don't have enough medical officers to cover neurosurgery. During the time I was working in hospital, hospital Ipoh.
Okay.
Right. So I was posted and requested to serve this neurosurgery. Then I was learning how the neurosurgery, how does it's been done, learning how to read the CT scans, assess the patient. It's totally different compared to a general surgery, obstetric gynecology, pediatrics, compared to even a common medical department. Mm-hmm. So this patient is totally different. Most of the patients that I see is trauma cases. How handle trauma, how to assess the GCS, Glasgow Coma Scale.
Okay.
So these are the things I learned, new things which I minimal touch on during my basic MBBS degree. So it's give me a new thing to learn. So the interest started, and then I slowly learned how to do a surgery when I was being trained as a medical officer. So I need to do, no other choice. During my time, that was 2005. We had only 4 medical officers doing calls and covering the whole para state.
For neurosurgery?
For neurosurgery.
Wow, okay.
So it was very difficult. So we need to be on call almost every other day. Then we need to do a lot of cases. And then it's supervised by a surgeon who comes from Kuala Lumpur the time. When that time there was one surgeon and then he quit. Then we are always supervised by the neurosurgeon how to do it. And then they will go back to care. Then we are alone for a few days. Then we need to continue doing surgery. So in that time, I learned a lot of things. Then improve my skills. And I thought, should proceed for
neurosurgery.
Why not? Then I see my patients, trauma cases, come to my clinic, get their sutures removed. I was so happy. A feeling of. Still now I collect all the pictures and I've taken the photos those days and I kept it there. And then remind me, who am I before and now. That's keep going.
Okay. Yeah. That sounds very inspiring. So I think when we talk about brain or like brain doctors, right? So there are two. there's a neurologist, and there's also a neurosurgeon. So I think up until now, people still get confused, like
Yes.
when do I see which doctor, right? So what is always the first step? Who do you see first?
Okay, what's the difference between a neurologist and a neurosurgeon? Neurologist, he will assess neurology of the patient who have symptoms, certain symptoms, right? So he'll assess it. That one, it can be medically treated. He'll treat for Parkinson's, certain infections, right? So when it needs a surgery, whether it's brain or spine, the neurosurgeon will take over. What neurosurgeon role is like? We are trained as partly neurologist and partly a surgeon. So that's we call as neurosurgeon.
So just now you mentioned about Parkinson's, right?
Yeah.
So does Parkinson is tremor like always the first sign of a Parkinson disease?
Yes, yeah, you are actually right. There's one was like resting tremor. There's particular unilateral one side tremor will be there. When they're resting, the finger will be moving, the hands are shaky. These are the things. The other signs are there: rigidity, bradykinesia, slowness. In a simple way, terms is they be slow, speech is slow. They feel the joints all stiff. These are the things can start. So yeah.
And you can't cure it via surgery?
Usual first line will be medical treatment. That's because of a lack of dopamine. So they start on a medication by the neurologist. And then there is the time where the medications is not working. Then we proceed for DBS, like when the patient is fit to DBS. So it's a deep brain stimulation. We insert microchips like that, small, very small, with the IGS guided, inserted specifically to the particular side of the brain. So we can control it, the tremor, by giving some impulse. Yeah.
So when we talk about brain surgery, how is it like compared from like 10 to 20 years ago? Is it generally more safer in this day and age?
Actually, it's a good question, If you think about it, maybe 20, 25 years ago,
25 years, yeah.
we not think about only technology, but think about human as well. We compare those days, 25 or 30 years ago, there's no proper neurosurgeons, yeah. So now we produce more neurosurgeon, especially USM, University Science Malaysia, where I get from. We produce our own neurosurgeon. We are pure neurosurgeon. And then we are specifically trained to learn neuroanatomy, neurology, and everything. So when come to surgery-wise, we are doing much more better compared to those days. Sometimes, long time ago, we have a neurosurgeon, but very few of them. So they cannot do the surgery for them. So they will train others, So the outcome is always not good. Now we have enough neurosurgeons. We need more, of course. Then now the surgery is much more safer, all right? Because some of the surgery is done by a neurosurgeon himself, and as well as they train the master students to become a neurosurgeon. They select. So now it's better. This is the human part. When it comes to technology, of course, we have CT scans, MRI, and IGS guided system where you can incorporate the images, MRI images, into a system where we can localize where you are going to operate. So it gives you a precise location where you're supposed to go. So you don't need to do unnecessary opening, unnecessary removal of the part of the tissue, and yeah.
And how about during the surgery itself? Would you say that robots a part of neurosurgery? Because like macam in urology, for urology punya surgery kan, I think now they're moving towards using robotic surgery. But would you say the same for neurosurgery as well?
When it comes to neurosurgery, honestly, I'm telling you, robotics, yes, is coming up, but it's not advanced yet. In our country, I'm not very sure about that. But robotic, yes, of course, certain technology usage in the neurosurgery is robotic, but especially when it comes to microscope, it has some features of robotic features, where it has its own memory, picture memory, that when you press it, take a photo of the images during surgery, right? When you move the microscope, you want to do some other things, then you press the button, it can come and readjust back to the same place.
Position. Okay.
Yeah.
Right. Okay.
Yeah.
That's interesting. Okay.
Yeah.
So let's talk about some of the misconceptions that people have about brain surgery, right? So a lot of people, when they want to undergo a brain surgery, they have this fear of, what if I do a brain surgery and suddenly I lose my memory? So is that always the case, or is that just like purely a misconception?
Yes, I agree. It's purely misconception. But first of all, why the patient needs a surgery, isn't it?
Mm-hmm. Yeah.
They should have symptoms. Some patient comes with the memory issues. Some patient will come has behavior changes, isn't it? So when we do a scan, there be a tumor. That means the tumor is causing the issue. So when that patient needs a surgery, let's say. So you want to do a surgery. So the tumor has caused some issue to the patient where the symptom comes, right? So we have to, as a surgeon, we have to consider that damage already done. So how am I going to remove the tumor without further damage to the brain?
Okay.
That's very challenging. So let's say the tumor cause issue about 40%.
Okay.
When I do damage as well, isn't it? So I do opening the scalp, cut the bone, go to the brain, and then retraction, all the stuff that I do. But I will always stick to less than the tumor.
Okay.
All right? So we remove the tumor safely, and the damage we cause should be much more far lesser compared to the disease itself. Yeah.
Okay. So when we talk about the tumor and you having to operate it to remove it, so I think back earlier in January, right, KPJ Sabah actually achieved like a new milestone, becoming the first private hospital to do an awake craniotomy or an awake brain surgery, basically.
Yeah.
And you were the lead surgeon. So why, in specifically this patient, right, required the brain surgery, and how it actually differs from a conventional brain surgery?
Okay, when we want to do awake craniotomy, it's not awake craniotomy is something new to our country.
Okay.
It's already done in so many places, in government public hospital as well as private hospital. For Sabah, KPJ Sabah is the first, of course, in 4. Yeah. So there is a clear-cut indication why we choose. One indication, the location of the tumor or lesion, where is it located? Is it frontal lobe, or temporal lobe, or parietal lobe, or occipital lobe? So each part of the brain has a specific function. So if it is located in a speech area, you need to locate the speech center first, and you label it by numbering it, and then you try to avoid the injury when you're removing it. When you remove it, we have a use of probe, so we stimulate. So if it is stimulated and the speech disruption occurs, so you try to, if there is a little bit of tumor stuck to that particular area, it's better to leave it alone. And then it can be handled by chemo or radiotherapy. That's a safe tumor resection. That's where we complete. Yeah. And sometimes the tumor can be located as like a motor cortex, where your movement of hand and leg. So we try to avoid that by doing this procedure. So there be a continuous communication with the patient. We do that to get a safe surgery. So patient also particularly very important. Not all patients fit into awake craniotomy, right? So because the fear of doing awake craniotomy always there, right? So the patient need to be educated at least 1 or 2 days before. We have to tell there are few tasks I have to give to the patient. They have to do. They have to realize what they're going to do. It's like I provide images like apple, lorry, and house, and written task like they have to say it what they see.
Okay.
All right, and pronounce it.
Okay.
And then I'll do a simple task. They're imaging, the patient seeing actually the screen, and then they say, tell me the days of the week, tell me the month of the year. I will keep on listening it while I'm doing surgery. right? So,
Okay.
is there any interruption between? Is there any hesitation? Yeah, that's most important. If you have to check the fluency of the speech, you have to do that. Another one, we have a task like counting 100 minus 7 backward. Yeah,
Okay.
yes, yeah. So that's important to do while we are doing that. So we keep on talking, but I have my own microphone with me, and as well as the patient. Yeah. So we keep on communication. Communication very important, and the patient need to be realize what they are doing. All right. So if certain patient become agitated, sudden panic attack, these are the things can happen. So patient selection is important. A patient need to be educated well before this procedure.
Okay.
Yes.
So not all patients
No.
would be suitable candidate.
Yes.
So you mentioned that there are certain mechanics where, during the awake surgery, where you will test their, whether are there any interruption ke, whatnot.
Yes.
So macam similar case like in the UK, right, where the patient had to play a violin. So
Yes.
is that also like
Yes, yeah, you're right. He's stimulating the motor cortex actually
Okay.
of the hand, right? So that surgeon is operating on the motor cortex. So when the patient is playing guitar, right, you can hear. So suddenly the hand drop or cannot move. When he's stimulating, he knows that this particular area need to be avoided.
Okay.
So, yeah.
So what is it like talking to a patient during the brain surgery? Does it like disrupt your concentration or how?
No, it be feel peace talking to them.
Okay.
Because it's like sitting in a clinic.
Mhm.
Yeah, our tone will be more specific, the task oriented. So when we are closing and finishing, I'll keep on talking about it. So
Okay.
I'll be informing her, yes, the patient, yeah, the surgery is done very well. Now it's going to close soon. Are you okay? Yes, I'm okay.
Okay.
You feel pain? No pain. Any score? Zero pain.
Zero, okay.
Yeah, that's most important.
Mhm.
Yeah, the patient will not feel any pain during the surgery.
Okay. So let's circle back earlier when we talked about misconception, right?
Mm.
So I think there is still a lot of misconception, especially in the elderly, where, like you complain of sakit kepala, migraines, and then they relate it back to excessive usage of gadgets. So is that actually a cause, or is that purely another misconception?
No, not misconception. Too much usage of gadgets like phone.
Mhm.
Now we use a more screen oriented.
Yep.
Those days we don't have screen. Yeah, so usage can strain your eyes, can even can stimulate your headache. As you cannot sleep.
Mhm.
People like to see their phone all the time before you sleep.
Yep.
After wakes up,
Mhm.
so you strain your eyes as well as your brain.
Okay.
Your eyes are directly connected to your brain, right? So these can trigger your headache. Yes.
Okay, so let's talk a bit on stroke, right? So, when we talk about stroke, the common understanding is that it actually only affects the elderly people, but I think now we're seeing a rise in younger adults as well. So, why is this a cause?
Actually, you're right. Yeah, we can see more commonly very young patient. My youngest patient was 24 years old.
Mhm.
Yes, youngest patient, very young. But the problem is, yeah, when come to another role is the genetic,
Okay.
family history of hypertension, history of stroke, heart disease in them, as well as patient diet, lack of physical activity.
Mhm.
These are the things they have get approved, and also the accident.
Mhm. Okay.
So motor vehicle accident, injury to the vessels can trigger. Of course, the heart disease can trigger emboli,
Mhm.
a stroke like that. It can happen.
So you
Yeah.
talked about accident, right?
Yeah.
So I think a lot of people when they're playing with sports,
Yes.
I mean injury is something inevitable. At some point you would get injured playing sports, or
Yeah.
even like going out, like suddenly car crash, right?
Yeah.
So what actually is the first symptom that you should not ignore before
Okay.
seeing a doctor?
Most important, if you headache,
Mm-hmm. Okay.
continuous headache, persistent headache, and then associated with the vomiting. Sometimes only headache. as a vomiting, as well as you feel a blurring of vision. So it's a sign of raised intracranial pressure that triggers you go to hospital. Better, yeah.
Okay. So earlier we talked about technology, right? So would you say that now, in this day and age, people in Sabah and also East Malaysia, because I think this region, I think most people would think that, you know, they don't have access to good healthcare services. But would you say that now, in this day and age, they actually have access to all the good medical healthcare, I would say, or like brain surgery? Is that because I think like back in those days they would have to be transported to Klang Valley to actually do just the brain surgery?
Yes.
But now would they have like those access here?
Yes, compared to those days, Sabah is much more better right now. I would say we can do the same thing what in West Malaysia can do. Yes, of course. We can
Okay.
do a safe surgery. That's
Okay.
no issue.
Right.
Whether it's brain or spine, we can produce the best.
Okay. Right. So before we end this session, right, actually, what are the top 3 things that people should actually do to protect their brains?
Okay. First of all, young generation, I would like to say that quit smoking.
Okay.
Make sure adequate physical activity, good exercise. Second is learn a new language. I recommend that. That's improve your brain function actually. You should try to learn a Mandarin or a Tamil. That's good actually. Other things, sleep well. The third one, sleep well. Good rest, and try to manage your stress at home.
Okay.
That'd be best for your brain.
Okay.
Yeah.
Right.
What we do on 20 to 40 will be you will see it in 60 to 80. Yes.
Okay. Right. Thank you so much, Doctor, for joining us today. And to everyone watching, stay tuned for the next KoPiJom episode.
Thank you, Ms. Vina.